السلام عليكم. Good evening everyone. نرحب بحضراتكم جميعا، أساتذتنا، زملائنا، أصدقائنا في ال second webinar of Iraqi Stroke Network through the educational program. This network is established to increase the awareness and interconnect stroke specialists and neurologists about stroke care. Without further ado تفضل الأستاذ معتز فيروز لتقديم الويبينار. تفضل أستاذ.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. This is our second meeting, a webinar meeting in Iraqi Stroke Network. It is my pleasure to be here with you for the second time, and I'm so happy with the presence of our great teacher, Mr. Dr. Sarmad Al-Fahad. He is the founder of the Iraqi Board of Neurology. We consider him as the teacher of the teachers, and he is the father of neurology in Iraq. حقيقة سعادة بالغة اليوم أنه نتكلم عن موضوع مهم جدا بالنيورولوجي، موضوع الستروك. لسنوات طويلة ظل هذا الموضوع هو underestimated و under evaluated. مع جزيل الأسف نحتاج هكذا شبكة وهكذا جهود لأجل raising the awareness about the stroke, starting from the risk factors and not ending with the post-stroke rehabilitation. We need a lot of work, and I hope this will be the first step in the right way. For a long time, we treat stroke in a conservative way, waiting for the aftermath of the insult. But today, I hope we have reached nearly to the modern ways of management of acute stroke, as my colleagues will start soon. And I hope after this, we will continue on the same rhythm and will achieve our goal in instituting a stroke society and starting stroke units as the modern world. شكرا جزيلا دكتور مصطفى ودكتور علي المؤسسين لهذه الشبكة. شكرا جزيلا لجميع الزملاء الحاضرين والمتحدثين، وشكرا جزيلا للأستاذ سرمد لحضورك هذا الويبينار. شكرا جزيلا.
شكرا جزيلا أستاذ. Thank you very much for this introduction. Today we will talk about, in general, about the state of stroke management in Iraq, and specifically we have three prestigious speakers throughout the country. We will start with Dr. Tamim Majid. He will talk to us about how to update stroke care in Iraq. Dr. Tamim Majid is well-known interventional neurologist in Iraq, and he has special. Currently he is the director of neurovascular catheterization department at Saad al-Witr Hospital in Baghdad. He is a fellow of the Iraqi Council of Medical Specializations Neurology, and he is a fellow of interventional neurology and stroke. Dr. Tamim has graduated from Kufa Medical School at 2008 and completed his neurology training at 2010. Please, the word is yours, Dr. Tamim.
Thank you very much. بالبداية أتقدم بالشكر للدكتور معتز على المقدمة الرائعة، وترحيب خاص طبعا بأستاذنا الكبير دكتور سرمد الفهد، وفخر أن حضورنا بالمحاضرة اليوم احنا نقدمها. كذلك أتقدم بالشكر للقائمين على شبكة الجلطة الدماغية العراقية، وبالأخص دكتور مصطفى كريم على دعوته الطيبة اللي تسمح لنا مشاركة بعض السلايدات عن محاضرة حول طرق تحديث علاج الجلطة الدماغية بالعراق. ما أعرف الشاشة هسه شاركت يمكم، لو ما أعرف لو واحد يعطيني خبر.
نعم واضحة جدا.
Okay, so we go. So our lecture today is about how to update stroke care in Iraq, insight from the mission thrombectomy white paper. These are a few slides about facts about stroke. I will go very fast because I think most of us, they know these facts. About 80% are ischemic stroke and about 20% are hemorrhagic. This is the global map, revealed the global burden of stroke. And our most interesting is the large vessel occlusion stroke, which may represent up to 1/3 of the total acute ischemic stroke population. Current option for treatment of acute ischemic stroke include first, intravenous thrombolytic therapy, second, mechanical thrombectomy, and third, combination of mechanical thrombectomy and intravenous thrombolytic therapy. As you know all, American Heart Association approved the intravenous thrombolytic therapy since 2013 and in a time window up to 4.5 hours. And at 2015, the American Heart Association approved mechanical thrombectomy for the first time for selected patients for up to 6 hours from the time of onset of symptoms. After that, after the Diffuse 3 trial and Down trial, the American Heart Association extended the time window for mechanical thrombectomy in selected patients for up to 16 to 24 hours after onset of the symptoms. This map showing the deficit in the stroke service globally, and about 80% of the all stroke centers are available only in the United States, United Kingdom, Brazil, France, Germany, and Australia. And even so, currently in the United States, only about 20% of the population has access to thrombectomy stroke centers. So the deficit in the service is very huge. For that, the Society of Vascular and Interventional Neurology, which is known shortly SVIN, in 2016 has launched the Mission Thrombectomy 2020, which is a global champion to drive regional public health efforts to improve stroke care by increasing the annual rate of thrombectomy procedure due to the disproportionate impact of large vessel occlusion stroke on overall long-term stroke disability. So, at 2021, the Regional Committee of Iraq was approved from SVIN with Dr. Fawaz Al-Mufti as the core executive committee representative, and Dr. Osama Mansour as the global co-chair, and Dr. Muhammad Al-Ghanim as the United States liaison, and Professor Hassan Aziz Al-Hamdani as the neurologist co-chair, and me and Dr. Mustafa Al-Khassaf as the interventionist co-chair, and other members which include Dr. Khalid Ambar, Dr. Mutaz Fayruz, and Ahmed Rashid, Dr. Ahmed Rashid. So the first Iraqi Regional Committee virtual meeting was done at 24th of January 2021 between members and Dr. Muhammad Al-Ghanim and Dr. Fawaz Al-Mufti through Zoom. After that, with several meetings, we discuss and we are trying to answer the question how to update stroke care in Iraq, starting from the stroke mechanical thrombectomy, the white paper, which published from Mission Thrombectomy. So these discussions, we should focus on the journey of patient with stroke. The patient have journey cross through several levels, start from pre-hospital recognition and transport, emergency assessment at emergency department, diagnosis by using CT and MR, and after that, therapy if it is the patient is elected for intravenous thrombolysis or mechanical thrombectomy, and finally, rehabilitation. The first job was to assess the efficacy of the existing system in a place for management of stroke and identifying the key gaps in the system at several levels, including the education, transport, diagnosis, stroke care unit, thrombolytic therapy, mechanical thrombectomy, management of complication, and rehabilitation. About local clinical guidelines, the committee is working on modify key recommendation of stroke care to the local environment. Each recommendation should be adjusted to the reality of each country. And we are working or should work on establishing regional accreditation programs for stroke hospitals to be recognized in presenting stroke services. Also, we should work on setting up stroke care units dedicated for intravenous thrombolytic services. And we should work on setting up specialized regional thrombectomy systems of care that are equipped to carry out mechanical thrombectomy. Also, we should develop our local training program for neurointerventionists with an aim to create adequate talent for the management of large vessel occlusion stroke cases. And we should work on developing stroke education programs focusing on symptoms, seeking emergency care, and available stroke system resources. The reality of the stroke services which are currently present in Iraq, according to the guideline published from the World Stroke Organization, showing we have only at secondary stroke prevention, we have advanced stroke care, while in the acute and the pre-hospital care, we have only minimal health care. And in the stroke rehabilitation and community reintegration and stroke system development, we are less than minimal services. So our committee top challenge identified by our committee was first, there is no public awareness about mechanical thrombectomy, nor thrombolytic therapy. Second, there is no national health program for stroke mechanical thrombectomy, nor for thrombolytic therapy. Third, there is no local training program for interventional neurology. Fourth, there is no stroke units. And fifth, there is no dedicated neurovascular cath lab. So the top 5 public health interventions identified by our committee was, first, we should launch media programs to increase awareness about mechanical thrombectomy and thrombolytic therapy. Second, we should launch national stroke management program. Third, we should develop new national stroke management guidelines. Fourth, we should establish stroke units and should establish dedicated neurovascular cath lab. After these meetings and discussions, we collect our ideas and our solutions, and we put it in one paper with the name of Updating Stroke Care Program in Iraq. After that, I met the Ministry of Health to present the white paper and the proposed updating program for stroke care in Iraq at the 2nd of January 2021. After that meeting, the Minister of Health was very supportive, and several meetings with the ministry board members was met to goals for establishing dedicated neurovascular cath lab in the Dr. Saad Al-Witri Neuroscience Hospital. Second, to establish a new Iraqi stroke guidelines. Third, to establish local intervention neurology training program. This is the 3 big goals we agreed with the Ministry of Health to go for. After that meeting, finally, a successful agreement was occurred between Ministry of Health and Philips to install the first dedicated neurovascular cath lab at Dr. Saad Al-Witri Neuroscience Hospital. And also our committee gets several meetings with Medtronic and their local representative, Maktab Assar. And we agreed to help in points which include training, developing national stroke system, and electronic proctoring, and developing best practice monitoring. Also, our committee get meetings with Boehringer Ingelheim and they decide to help us through their Angels initiative in points which include training, acute stroke network development, and best practice monitoring network. Finally, we succeed, and our cath lab machine was settled in مستشفى دكتور السعد الوتري. هسه راح أبدي أحكي بالعربي. هاي هي شعبة القسطرة الدماغية في مستشفانا، اللي هي تتكون من غرفة القسطرة، وهذا الجهاز عندنا اللي هو ثنائي المحور ومخصص بشكل أساسي لعمليات القسطرة الدماغية، إضافة إلى وحدة العناية المركزة اللي هي مجهزة ب6 أسرة مخصصة للعناية بالمرضى بعد القسطرة الدماغية. وهذه هي غرفة الإفاقة بسريرين، وهذه هي وحدة السكتة الدماغية اللي مجهزة ب4 أسرة، وهذه هي الغرفة التعليمية. في يوم 25/9 تم إجراء أول عملية قسطرة دماغية في الشعبة كفحص الجهاز، ثم بدأ التشغيل التجريبي بعدها. وفي تاريخ 5/10/2022 بالتعاون مع شركة مترونيك مكتب السار تم زيارة فريق طبي من مستشفى الدكتور سعد الوتري إلى شعبة السكتة الدماغية في مستشفى جامعة عين شمس المصرية لنقل تجربتهم الناجحة في مجال القسطرة رغم قلة الإمكانيات. وفي نهاية شهر 12/2022 تم الافتتاح الرسمي لشعبة القسطرة الدماغية، والآن نقوم بإجراء عمليات القسطرة الدماغية التشخيصية بشكل يومي، وبانتظار رفد الشعبة بعدد كافي من أطباء التخدير ومساعدي التخدير والممرضين، ورفدا أيضا بمستلزمات اللازمة للعمليات العلاجية لتشغيل وحدة العناية المركزة والبدء بإجراء العمليات القسطرة العلاجية. بتاريخ 16/1/23 حصلنا على بيان استحداث الشعبة رسميا من الوزارة، وتم إضافتها إلى هيكلية مستشفى الدكتور سعد الوتري. وفي الشهر الرابع تم إضافة جميع مستلزمات علاج السكتة الدماغية قسطاريا إلى ملازم الاحتياج وقوائم الاستيراد في وزارة الصحة العراقية. وإن شاء إن شاء الله على سنة 2024 المفروض كل الكافيترات، الوايرات، الشبكات اللي نحتاجها إنه هي موجودة من ضمن تجهيزات كيماوية. وفي الشهر السادس صدر رأي دائرة العيادات الطبية الشعبية بتصنيف عمليات القسطرة الدماغية إلى عمليات كبرى وفوق الكبرى وخاصة، لأن سابقا كانت هي ما مدرجة ضمن نظام التصنيف مال وزارة الصحة. وفي شهر العاشر صدر قرار اللجنة الوطنية لانتقال أدوية من مخاطبة 5 مستشفيات في العاصمة بغداد لبيان استعدادها لتشكيل فريق الجلطة الدماغية، أو لبيان إن كان لديها وحدة جلطة دماغية أصلا. كذلك في الشهر العاشر صدر الأمر الوزاري الخاص باستحداث لجنة استشارية لغرض تطوير علاج الجلطة الدماغية، طبعا بعضويتي وعضوية الدكتور نمير محمد طاهر وعضوية الدكتور حسام عبد الرسول. وحاليا نعمل باللجنة على النقاط التالية: أنه أولا احنا طالبنا بإقرار البرنامج الوطني للسكتة الدماغية، ورفع الطلب إلى معالي الوزير بانتظار الجواب. كذلك نعمل على إقرار ضوابط سريرية عراقية جايد لاينز علاج السكتة الدماغية، ونحقق نحاول نكيف الجلوبال يعني recommendations للانفايرمنت العراقية، لأن احنا ما نقدر كل شيء مكتوب مثلا بالأمريكان هارت اسوشيشن أو اليوروبيان نطبقه. بدنا نحاول نسوي في التكييف معين بحيث نسوي جايد لاين عراقية قابلة للتطبيق. ثالثا نحاول انه نعمل على ارسال اطباء للتدريب والدراسه خارج قطر، ونعمل على استحداث دراسات محلية للأطباء والكوادر التمريضية بخصوص علاج السكتة الدماغية. طبعا كلش مهم عامل انه التمريض انه يتدربون على العناية والمراقبة، لانه تدرون انه بعد الاكتيليز وبعد الميكانيكال ثرومبكتومي يعني رادنا انتنسيف مونيتورنج كلش قوي. وهاي نسخة أولية من الاستمارات اللي بدنا نشتغل عليها، إنه نحاول إنه نعممها بحيث إن شاء الله من يكمل الجايد لاين يكون باستمارات من الدخول بالطوارئ إلى الموافقة الخطية، إلى قرار طبيب الأخصائي الجملة العصبية، إلى أنه ورقة متابعة المريض بعد الاكتليز، ورقة علاج المريض إذا كان مثلا صار بتدهور شو تسوي مفراس حالة طارئة، وهكذا أوراق النزيف، وأوراق الحساسية، الأنجيو أديما، وكل هاي نريد تسويها استمارات كاملة بحيث أنه الطبيب الشيعتاز يلقى عنده موجود بالجايد لاين. وهاي هيك أنا خلصت المحاضرة، وشكرا على حسن استماعكم.
شكرا جزيلا دكتور تميم،
شكرا جزيلا دكتور راشد.
لا العفو.
مباركة وجهود جبارة بصراحة. صراحة احنا إذا يسمحوا لي الأساتذة والزملاء يعني ما كنا عندنا علم بهاي التطورات. عاشت ايدك عمي، وشكرا جزيلا لجهودكم، انتم بعد
لا
مقصودين،
العفو.
وان شاء الله نتائج مرضية بإذن الله.
يعني هو الحقيقة احنا بدنا نشتغل من فترة طويلة على الموضوع، بس هي الظروف العراقية العامة بدها تأخر. يعني هو ماكو أحد ضد الموضوع، لكن ماكو يعني أولويات غير شكل للوزارة، للقائمين على الوزارة عندهم أولويات أكثر، يعني لا أكثر لا أقل. بس إن شاء الله هسه الأمور شوية تحسنت بالفترة الأخيرة آخر سنة.
ان شاء الله. فضل جهودكم ومتابعة
إن شاء
منوني منكم، شكرا جزيلا. طبعا نذكر الحضور we remind the attendees to put their question in the Q&A and chat box. Next speaker. Our next speaker from Erbil, Dr. Srood Nizar Jirjees. He is interventional neurologist. He is a fellow of Iraqi Board of Medical Specialization since 2010, and graduated from Medical College at 2003. He currently had Isment stroke diploma and specific neurointerventional training at Turkey, and currently working at Rizgari Teaching Hospital in Erbil. He will tell us about the RTPA in ischemic stroke and about their experience at Erbil City. The word is yours, Dr. Srood.
بسم الله الرحمن الرحيم. السلام عليكم. Thank you for everyone for the attending this webinar, and special thanks for our teacher Dr. Sarmad Al-Fahad, and for Dr. Mutaz, and for Ustad Hassan Al-Hamdani for attending our talks. So I will try now. Okay.
يا دكتور بس
So
تمام.
okay, so I try to share now my sorry. Okay, is it clear now?
Here,
My
but
screen
is the screen of the audio.
sorry. Is it clear now?
نعم here.
Okay. So I will talk about the RTPA in ischemic stroke and our experience in Erbil City in managing and caring stroke patients. So alteplase, RTPA or alteplase is a thrombolytic agent that's manufactured by recombinant DNA technology. It is FDA approved for use in acute ischemic stroke, pulmonary embolism, and acute myocardial infarction. Alteplase is a fibrinolytic agent. It also is referred to as tissue plasminogen activator. So it's a recombinant tissue plasminogen activator that converts plasminogen to the proteolytic enzyme plasmin, which lyses fibrin as well as fibrinogen. Intravenous alteplase is cleared primarily by the liver with an initial half-life of fewer than 5 minutes and a terminal half-life of 72 minutes. So starting with the administration of RTPA started with the NINDS trial, where they started to give RTPA within 3 hours to a number of patients, and they found that patients have about 30% respond in 90 days, better than control patients, better than controls. Then the ECAS trial, ECAS 3 trial has come to extend the RTPA window to 4.5 hours. And then the extend trial extended that they tried RTPA in wake-up stroke in between those unknown time or onset of the stroke. They extended to about 9 hours, giving RTPA, but for selected patients with specific neuroimaging features like diffusion-weighted flare mismatch. So the recommended dose is 0.9 milligram per kg, and the total dose should not exceed 90 milligram. And 10% of the total dose gets administered as an intravenous bolus over 1 minute, and the remainder will be infused over 60 minutes. So who can receive RTPA? Those patients who have stroke that causing a measurable neurological deficit. We mean either it is the NIH score is more than 5, or even if less than 5, but if it is measurable, disabling stroke like dysphasia or homonymous hemianopia, we can give them RTPA. And the onset should be less than 4.5 hours before beginning treatment. If the exact time of the stroke onset is not known, it's defined as the last time the patient was known to be normal. And the age should be more or than or equal to 18 years. So the exclusion criteria is that patients who have severe head trauma or ischemic stroke in the previous 3 months cannot receive RTPA. And patients with intracranial hemorrhage, patients with previous intracranial hemorrhage, patients with axial intracranial neoplasms, gastrointestinal malignancy, gastrointestinal hemorrhage within previous 21 days, and intracranial or transspinal surgery within the previous 3 months. These were points in the history. Regarding clinically, if we have features that suggestive of subarachnoid hemorrhage, or persistent blood pressure that is systolic more than 185 or diastolic more than 110, or if there's active internal bleeding or features of infective endocarditis or aortic arch dissection are exclusion criteria for RTPA. Hematologically, platelet counts of less than 100,000 or current warfarin with abnormal INR or PT or PTT, prolonged, or therapeutic low molecular weight heparins receiving within 24 hours, or new oral anticoagulants received within 48 hours with the evidence of abnormal laboratory results like abnormal APT or INR or e-carrying clotting time or thrombin time. And also presence of hemorrhage in the CT or extensive regions of obvious hypodensity consistent with irreversible injury. What about the complications? So we have two important considering complications in RTPA. That is symptomatic intracerebral hemorrhage, which accounts for 2 to 7%. So this point should be discussed with the family of the patient or the patient is himself regarding the risk of hemorrhage. And the second is the orolingual angioedema. So if there is intracerebral hemorrhage, we should stop altiplase infusion immediately and send for urgent CT and for CBC, PT, APTT, fibrinogen level, and type and cross match. And we start to give cryoprecipitate or tranexamic acid if cryoprecipitate is not available or patient is not suitable to take it. And hematological and neurosurgical consultation is mandatory also supportive therapy, including blood pressure management, monitoring of intracranial pressure, temperature, and glucose control. In orolingual angioedema, endotracheal patient may be indicated, but if the edema is limited to anterior tongue and lips, there is not indicated for edema, for endotracheal intubation. It's indicated if there is the floor of the mouth or palate or oropharynx, and if there is a rapid progression of this edema within 30 minutes. And awake fiber optic intubation is optimal in these patients. Then we discontinue IV alteplase, of course, and we administer intravenous methylprednisolone, diphenhydramine, ranitidine. Also, if the angioedema continues, we can administer epinephrine too. So these were for a few points about RTPA. And now I'll talk about our experience regarding stroke care. So we started since 2010, we admitted stroke patients in the neurology ward in Rizgari Teaching Hospital. Patients mostly received at that time care and secondary preventive treatment, and critical cases have been admitted in the ICU unit of the hospital, and cases who needed surgical intervention have been referred to neurosurgical department. Since 2018, RTPA have been administered to selective patients. So in 2018 and 2019, about 16 patients have received RTPA at emergency room and ICU. 9 of them were males and 7 females. And all but 1 of them received RTPA within first 3 hours. 9 patients, that means 57% of patients, recovered completely or completely. That's was about 2 in the follow-up. 4 patients recovered partially, or follow-up was not done completely. 3 patients died, 2 patients due to large vessel occlusion with big infarction sizes. One of them developed small hemorrhage. Most probable causes of death were pneumonia. That's not directly related to RTPA. In 2020, 2021, with COVID challenges, was difficult to administer RTPA in time. So the cases have been diminished receiving RTPA, and recordings were also reporting documentation were difficult. So these are some cases who are recorded at that time. And so a case, a 50-year-old male smoker, hypertensive with right MCA infarction and NIH score, received RTPA. NIH score changed from 6 to 3, and there was no complication. Another patient for diabetic and hypertension with left MCA infarction received RTPA, and NIH score changed from 8 to 2 with no complications. Another patient, 45-year-old female with right MCA infarction with dramatic response after 2 hours, received RTPA with 90-year-old male patient also developed present with right cellular weakness and complete facial weakness with NIH score 8, received RTPA within 4 hours, but failed to respond. That was the NIH score after 48 hours was the same, and there was no complications. 70-year-old female patient with MCA stroke, NIH score 18, and the time was 2 hours, received within 2 hours, RTPA, and also failed to respond with no complication. So recently, we have given RTPA to this patient with 55-year-old male who was 55-year-old male, was smoker, hypertensive, and diabetic, presented with left side upper limb and lower limb weakness, grade 0, and partial facial weakness. NIH score was 10. RTPA given at 2.5 hours. After NIH score, their scores reduced to 3. So I would like to just share this video with you. 2 videos. This video, I don't know if it is clear or not.
Not yet.
Sorry. Now,
كاك جاسم دستي راسة بنكا
is it clear now?
Yes.
Okay.
دستي شكت بنكا حركي في هيش نعتاني أو لا قد بنكا بلنديكا نعتاني
Okay. This is after 2 days from receiving the RTPA.
كاك جاسم دستي راسة بنكا
Sorry, excuse me.
كاك جاسم قاعد دست بنكا استا يلا بلنديكا دي بقوة ايشتان لاقت بنكا زور باشا بلنديكا دي بقوة اشتا تمام.
Okay. So then also, excuse me, just okay. So also recently, I had a case who was who was 47-year-old female patient, hypertensive and diabetic, presented with wake-up stroke, complaining of severe Wernicke dysphasia with NIH score of 2. So even NIH score is low, but it is disabling stroke. But it was a wake-up stroke. But during imaging, this is diffusion weighted that shows infarction in the parietal, and it's in temporal area also, but it's not shown here. And the flare is negative, there is no lesion. So according to the extent trial, I decided to give RTPA to the patient. After 24 hours, we did CT scan. There was no obvious hemorrhagic transformation. There was some petechial type 2 petechial hemorrhages, but it was non-symptomatic. So we decided to keep patient on low dose aspirin, and the NIH score changed it, the severe dysphasia changed it to mild dysphasia. Now I will talk about the neurointervention experience in Erbil. We have started since 2018 working and training with a Jordanian team in cardiology cath labs in some private hospitals. The Jordanian team includes 2 consultant interventional radiologists who visit Erbil periodically every 2 weeks. And recently, 2 interventional radiologists from Suleymaniye city also visit Erbil and help us in emergency cases. More than 1,000 diagnostic cerebral angiographies are done. About 300 brain aneurysms were treated. 45 with flow diverters. These are special types of stents. Around 40 with stent-assisted coilings, and the rest by coiling only. Around 40 IV malformations have been treated. Around 100 carotid stentings have been done. Around 3 to 4 mechanical thrombectomy have been done, and this is due to time challenge because the team is not available 24 hourly in Erbil city. Nearly 10 cases developed acute complications. 3 of them died due to massive intracerebral hemorrhage, 1 major stroke, and 6 minor strokes. 2 cases died after a while from intervention, around 3 months, 1 due to ischemic stroke and other due to recurrent bleeding. I will talk about some examples for cases who have been received neurointervention treatment. 60-year-old female patient, hypertensive diabetic, presented with acute headache, neck stiffness. The CT showed subarachnoid hemorrhage. This is a diagnostic angiography that showed this aneurysm in the middle cerebral artery with the blip, with the daughter cyst that is the cause of the bleeding. We tried coiling in this patient, excuse me, okay, sorry. So we tried coiling in this patient, but it does not fit, it does not fit due to wide neck. So we plan to do stent-assisted coiling in the next visits. Another patient, 61-year-old female, presented with acute headache. CT brain was negative, but lumbar puncture indicates subarachnoid hemorrhage. And the CT angio was negative. Then we did this diagnostic angiography, which showed this small aneurysm, para-ophthalmic saccular aneurysm.
أنا آسف للمقاطعة بس الوقت بيرازم عليك وكان
نعم العفو.
فنوني.
نعم إن شاء الله باقي سلايدات قليلة. Okay, so this patient, 17-year-old female, presented with sudden loss of consciousness, and CT showed this massive subarachnoid hemorrhage, intraventricular hemorrhage, and brainstem hemorrhage. This is the CT angio, showed a huge AV malformation in the posterior circulation, and this is the diagnostic angiography, showed this AV malformation with the feeders from the posterior inferior cerebral artery and the posterior cerebral arteries. And this is in the first session. After first session of embolization, this is the embolization area, about 50% of the AVM has gone. Another case is 49-year-old female presented with acute severe headache with neck stiffness, and CT showed subarachnoid hemorrhage. This DSA showed about 2 aneurysms, one of them in the A1, A2 junction, and the other one, this is another aneurysm in the ICA. So 2 aneurysms in one patient. So this is the another aneurysm in the ICA, which is more clear here. So first aneurysm is coiled. Here is coiling, and the second one is stented by flow diverter. This is the flow diverter, and this is another aneurysm which shows fainting and sluggish of the flow, which is indication for regression after a while. This is the last case, 68-year-old female, also presented with subarachnoid hemorrhage, and DSA showed this aneurysm in the anterior communicating artery, which was coiled. And at the end, I would like to thank all my colleagues, neurologists and board students in the Rosgari Teaching Hospital who are critical partners in our stroke care. Thank you.
Thank you very much, sir, for this. We will skip to the second speaker. According to agenda, we missed about 10 minutes, less than 10 minutes. So our next speaker will be Dr. Ahmed Abdul Salim. He is based in Basra. He will tell us about non-interventional reperfusional therapies in acute ischemic stroke and the role of stroke center. Dr. Ahmed is currently working at Basra General Hospital and lecturer at Basra College of Medicine. He is a consultant neurologist and he is a fellow of Iraqi Council of Medical Specializations since 2013. And he was also a fellow of American Academy of Neurology. So the word is yours, Dr. Ahmed. I'm afraid you are muted, Dr. Ahmed. Please unmute.
Hello, everyone.
تمام
Thank you, Dr. Mustafa, for this nice introduction to me. I hope in this presentation will be complementary for the other lecture presented previously from my other colleagues. I will speak today about non-interventional reperfusional therapy in acute ischemic stroke, and we will highlight about the importance of stroke center in this situation. So, the objective of this presentation is to clarify the role of stroke center in the management of acute ischemic stroke and to identify the importance of reperfusional therapy in the management of acute stroke center and to answer the question, is it applicable in our locality to establish a stroke center? What is the importance of stroke center? Why we are insisting to establish a stroke center to provide care for a patient who is victim for acute ischemic stroke? Because a stroke center is aimed to provide an specially trained person which is capable of dealing with different aspects of acute ischemic stroke management. What are these needs that are established by stroke center is to establish the diagnosis as early as possible, to provide reperfusional strategy because these treatments are the most effective intervention for acute stroke, and to provide adequate hemodynamic management, monitoring and management of acute ischemic brain edema, and early recognition and therapy of systemic complication that may occur in patients with acute ischemic stroke. What are the three main principles for the treatment of acute ischemic stroke? Is to achieve timely recanalization of occluded artery and reperfusion of ischemic tissue, and to optimize collateral flow and to avoid secondary brain injury. For the second one, is usually achieved by giving isotonic fluid, normal saline or Ringal lactate to improve collateral. And this is part of acute stroke management, and also it is could be part of secondary stroke management. While the third one is to avoid secondary brain injury, is achieved by prevent complications that may arise from different situations. For example, hyperthermia, hyperglycemia, hypoglycemia, other. So our main goal in acute stroke management is to achieve timely recanalization of the occluded vessel. And why this is important? Because even if the patient get infarction, there is an area around the infected area, which is an ischemic, but not yet to get infected. This is called ischemic penumbra. If we get reperfusion to this area, we will salvage this area and we will improve the neurological outcome by a lot. How we can achieve recanalization? Either by use the chemical thrombolysis using recombinant tissue plasminogen activator, which is also known as alteplase, and by mechanical embolectomy with retrieval stents. So, for acute reperfusional treatment, there is an incontrovertible evidence that IV thrombolytic with RTPA and endovascular thrombectomy with retrieval stent improve neurological outcome in patient with acute ischemic stroke. And there is around more than 200 randomized controlled clinical trial that show the efficacy of tissue plasminogen activator in the treatment of ischemic stroke. Some of them are mentioned by Dr. Srood, NANS, and CMA3 and others. But we have a time limit in order that we give the tissue plasminogen activator, which is about 4.5 hours from symptom onset. So in order to treat a patient with acute ischemic stroke, we need to take these consideration in our management plan. The first one is the time in which the patient was learned to be well, because the time limit is very important, and we are limited for only 4.5 hours to give the thrombolytic agent and only 6 hours for giving doing interventional cath, and maybe extended for special by special consideration into even 16 to 24 hours. The medical condition or recent surgery that could be contraindicated for thrombolysis, and we should do a neurological examination to calculate the NIHS score. And we, in the further slide, we see what is the importance of these points. And we should also take a capillary glucose level. We should also measure the blood pressure, and we should obtain a brain CT scan to exclude intracranial hemorrhage. The most beneficial time in which the patient can benefit from RTPA is about 90 minutes. The standard dose of IV RTPA for acute ischemic stroke is 0.9 milligram al kg with 10% administered as a bolus, and the remainder infused over 1 hour. But the total dose should not exceed 90 milligram. Why we ask about the question previously taken into consideration in the management of acute ischemic stroke patient? Because there is contraindication. These contraindications should be put in our mind if we want to give thrombolytic therapy, which are severe trauma in the last 3 months, ischemic stroke within the last 3 months, arterial puncture at non-compressive site in 7 days, previous intracranial hemorrhage, suspected subarachnoid hemorrhage, if there is AV malformation, if the systolic blood pressure is above 185 over 110, and the blood pressure should be reduced to 180 over 105 before giving thrombolytic therapy. If there is bleeding diastasis, if the patient take warfarin, INR is above 1.7, if the patient take warfarin within 48 hours with abnormal APTP time, the platelets, if it is less than 100,000, and if there is current use of thrombotic inhibitor within 48 hours, and the blood glucose is less than 50, or if the CT show hypodensity more than third of the hemisphere. Other relative contraindication are minor stroke if the NIH score level 5, if there is rapidly improving symptom, pregnancy, seizure, because it may be part of thought paralysis, major intracranial trauma, major surgery within 14 days, or gastrointestinal genitourinary surgery within 21 days, or acute myocardial infarction within 3 months. And there is additional contraindication if you want to give the patient a thrombolytic therapy from 3 to half and a 4.5 hour window, which is if the age is more than 80 and warfarin used regardless of the INR, and if the IH score more than 25, and if there is a previous stroke or diabetes mellitus. So, what we need in our locality in order to succeed in establish a stroke center, the most important is to educate our people about the stroke symptom and the importance of bringing the patient as early as possible to the hospital. And this can be carried out by media, by television, and by poster, which is maybe globally distributed all over the country. And to provide good trained medical personnel that are carefully choose the eligible patient for reperfusional therapy and are capable of dealing with stroke management aspect. And in our institution, we should have a stroke center which is capable to doing a brain CT scan and other modalities of CT scan, CT perfusion, CT angiography, and as early as possible, because the time is the key for success in treating patient with acute ischemic stroke. And this should be carried out by our health institute manager, should provide us with our need, CT scan and cath lab in order to make the stroke center work in our locality. So as a conclusion to my talk, acute stroke is a medical emergency in which every minute is count. Achievement of reperfusion can reverse neurological deficit, even severe, and allow patient to regain function. Providing nearby or portable CT is a major limitation to establish stroke center in our locality. Finally, I would like to highlight about my experience about giving RTPA in Basra. I give RTPA for 5 patients. 3 of them recover completely. 1 of them are only partially recovered. 1 of them, of the patient, which was female, about 80 years, have large MCA stroke, not respond, and eventually die in the ICU. So RTPA and other management of acute ischemic stroke, mainly the reperfusion, make a lot change in stroke treatment and should be considered and to be implemented in our institution. Thank you for all.
Thank you, sir, for this comprehensive talk. We are so delighted to hear this from Basra. Thank you a lot. We are sorry
Thank
for
you,
not keeping in the schedule. Now we are waiting for the panelist comments. We are delighted to hear from Professor Sarmad.
السلام أستاذ.
أنا أحب أهنيكم على الشيء اللي تعملوه, and I want to congratulate you for this success which you really deserve. It's very hard work because I used to try to do things in Iraq and I know how difficult it is. But with time, you will we see it will be much easier with time. You only need to persevere to continue what you are doing. And the more you experience you have, the better the results. And this will reflect on your students. You are going to create a new and a lot of people who will do this procedure in the future and will be good at it. So I would like to congratulate you and thank you for asking me to participate in this meeting.
Thank you a lot, sir. We are so delighted to hearing from you. The word is yours. دكتور معتز.
شكرا جزيلا للزملاء الحضور والمشاركين، وشكرا جزيلا لاستاذنا الكبير استاذ سرمد الفهد على حضوره وعلى تشجيعه، وان شاء الله هذه راح تكون فاتحه خير لفعاليات اخرى اكثر. حقيقه احنا عندنا الكثير من المشاكل تواجهنا فيما يخص علاج الجلطه الدماغيه. واحده من اهمها اتصور يعني يمكن هو الاندر استيميشن اوف ستروك دايجنوسيس. هذه واحده من المشاكل الكبيره. واثنين انه ستيل يعني اغلب مو بس المرضى، حتى اغلب الزملاء الاخرين هم يعتقدون انه case of stroke is hopeless regarding treatment. حقيقه لا، هذا المفهوم لازم احنا كنيورولوجيست نحاول نعكسه. we can do a lot for patients with stroke. دكتور مصطفى، دكتور علي، شكرا جزيلا لجهودكم الكبيره في انشاء هاي النتورك، وان شاء الله نبقى مستمرين بها ونوسعها ونتواصل اكثر واكثر. وركه الجهود مره ثانيه. اشكركم جميعا.
السلام عليكم.
شكرا جزيلا. Now, Dr.
Now
Ali,
we are started.
go on, Dr.
Sorry, the voice is here. أنا دكتور علي عبد الكريم، نيورولوجيست. أشكر أولا أشكر الله عز وجل على هذه الفترة الزمنية بأن يجعلنا تحت الأساتذة الخبرة الهيمة التي تعتبر من العناصر المهمة لدعم كل مشروع جديد لبناء مستقبل جيد لخدمة الناس. الآن نبدأ بالأسئلة التي لعلها لابد توجد لها أجوبة تكون لدى الناس الكثير من يسأل. العفو دكتور تميم, we have one question for you, please. The voice is here.
دكتور تميم, are you with us?
Sorry.
تفضل دكتور علي اسأل.
Now we have the second question with Dr. Srood.
Yes, I am hearing.
Dr. Srood, عفوا تسمعنا?
Yes, I am
Okay.
hearing.
Regarding to the okay, Tamam. Regarding to the RTPA, to the patient with acute ischemic stroke, we have a question. How is the situation of stroke awareness and stroke therapy awareness in Kurdistan region? We mean about the educational level in the people. Can explain to us, please?
Yes, okay. Yes, about actually the education is very low regarding the signs and symptoms of stroke and regarding the arrival of patients to emergency hospitals and emergency room in the hospitals, especially in Rizgari Hospital. Where we have RTPA and a neurology department calling is available 24-hourly there. So that's why over years we are trying to give RTPA, but there are little number of patients who are arriving in the time. But we are trying our best to catch those people who arrive early and to administer the RTPA at the time. And our senior house officers are well educated about dealing with acute stroke patients and with the liaison of the with the seniors. They try to give the RTPA for the patients who are coming in less than 4.5 hours. Although the patients who received in less than 1 hour, 90 minutes or 2 hours got more benefit, but we give RTPA for if the stroke onset is before 4.5 hours.
Thank you so much. We have we understand from this point the education level is still need more practice and more exercise to educate the people about this stuff, how to deal with it at home, at supermarket, at street, at any place, and how can reach to the specific point. Also, we have a trouble with the trouble T. The first of all is time and the trouble, and also the teamwork. How can advise? Sorry, about the RTBA. So patients receive a lot of patients receive RTBA. How many patients receive within 1 hour?
We have just one patient received in less than 90 minutes. We have no less than 1 hour actually. Just one patient received 90 minutes, less than 90 minutes, and about like 3-4 patients received less than 2 hours. But most of the patients received less than 3 hours.
Sorry, about the pacing problem. It is occurring this patient regarding to the patient with stroke and seizure. As we know, there is some point about stroke with seizure.
Yes.
We know there is thought paralysis. This is pacing problem. Is occurring patient with RTBA during this research?
Yes. So we have stroke mimics. One of the stroke mimics is the seizure and the paralysis that is combined or accompanied the seizure. This is actually one of the difficulties of giving RTPA in worldwide also. So according to our experience, if we have patients with age like more than 50 or 60 years, with risk factors of hypertension and diabetes, even if they are presented with seizures and paralysis, so we give RTPA if they are eligible for the RTPA. In order to
The last question, sorry, Dr. Srood.
okay.
Last question, sorry. If patient receive bolus, the RTBA, and get well, completely normal, continue to maintenance or not?
So in our experience, we didn't get patients who become completely normal after bolus dose actually, so we continued with the infusion. And so we all patients are received the full dose within 1 hour in the whether in the emergency room or in the ICU, and then we followed up them after 1 hour, actually after half hour, then after 1 hour. We have no experience with such patients actually.
شكرا جزيلا دكتور
Thank
سرور.
you.
والآن مع الدكتورة براء لتكملة بعض الأسئلة. دكتورة براء.
السلام عليكم. I'm Dr. Baraa, a junior doctor in my second year and have an interest in neurology. I'm here to raise questions to our doctors. I have a question from Dr. Tamim to Dr. Srood. Is there any stroke unit in Kurdistan or Erbil or the question you are in, Dr. Srood?
Yes. So we started dealing with the stroke patients. We have no yet a dedicated stroke center, but we have started to deal with the stroke patients in neurology department since 2010. We admitted patients in the neurology ward, and then in 2018 we started to give RTPA in the emergency room and the ICU of the hospital, and then refer the patients to the neurological ward after 24 hours if there are no considering complications. We are working on establishing a stroke unit in the Rizgari Teaching Hospital and together with the cath lab in order to be able to have a stroke center with a cath lab in our hospital.
Thank you, Dr. Srood. Questions now are going to Dr. Tamim. We have a question in the chat box from Dr. Hawarman. He asks, is there any data about number of stroke patients in Baghdad city per year?
Thank you for the question. Unfortunately, as my colleagues mentioned in their lectures, the usual incidence globally is about between 100 to 200 cases per 100,000 per year. This is the global incidence. I don't know about any specific data from Iraq, but one point in our protocol, what we are working on in our committee, the Minister of Health, is about stroke registration and to start in a good way, in right way, with stroke registry. We are working on a software which working online, which can give access for every hospital with online registration of every case of stroke, whether it gets only antiplatelet, medical supportive therapy, or get thrombolytic therapy or mechanical thrombectomy. We hope after starting this stroke registry, after that we will get real data about the incidents. Right now I have no answer for that question.
Okay.
بس العفو يعني إذا تسمحوا لي مداخلة بالنسبة للإنسيدنس يعني إحنا راجعتك ويسموه الكتاب الوطني وزارة الصحة اللي هو ينزل كل الداتا الموجودة. العراق مسجل 10 إلى 20 ألف وتعتبر كلش أندر استيميشن، لأنه الجزائر تقريبا 45 مليون مسجل 50 ألف، مصر 104 مليون أو 105 مليون مسجل 200 ألف، إحنا مسجلين 20 ألف. فاحنا عندنا مشكله كلش قويه بالريجستري، واعتقد السبب انه الكيسات يعني اللي صار ستروك قاعد تشخص اما نون ستروك او نيمونيا او كذا او تي اي او something يعني هاي. فاحنا ويرناو انه نحاول انه ناكد على المستشفيات العامه انه تسجل اكثر كيسات الستروك على ما نقدر نحصل خلينا نقول داتا امام الوزاره نقدر نحصل بها ريسورسز ونحصل بها يعني فاندنج او يعني امور اخرى. وبالنسبه لعفو الدكتور علي ولا مداخله، احنا يعني ان شاء الله بصدد يعني تاسيس البرنامج الوطني للسكته الدماغيه. واحده من المهام مالته هي الدعايه اللي تصير للمواطنين، واحده من عندها البوسترات، حتى ممكن نحصل على فاندنج له بوسترات دعايات بالتلفزيون ويا الصحه العامه ويا كذا. اكو يعني باذن الله تعالى خلال هالشهرين يعني 3 راح تخلص شغلات مرتبه وتكون جاهزه بالنسبه لكم يعني جميع العراق انه يقدر انه يتناولها وينشرها. نحاول نعزز المعرفه مال المواطن العادي البسيط بالساين سيمبتومز اوف ستروك. طبعا احنا نحتاج education للدكتورز يعني للكوميونتي بيست هوسبيتالز، يعني المستشفيات اللي هي عامه لكن قد تكون تحتاج الى تثقيف وإديوكيشن، خاصه هالمستشفيات اللي صارت قريبه من البيوت. هاي هم اكو بروجرام لها راح يصير انه يعني
حسام
نعم.
اتجاه التثقيف. أقول لك هاي إحدى الخطوات إن شاء الله في عراق ستروك نتورك، وبعد يعني المجهود الكبير هو على جنابكم باللجنة، بس هاي إحدى الخطوات إن شاء الله.
إن شاء الله، فإن شاء الله جاء الخطوات بإذن الله تعالى.
Next question for Dr. Tamim. What are the most important obstacles in applying stroke program, and what is your advice to overcome them?
هذا أهم سؤال، وهو المشكلة الحقيقية. الأوبستكلز عندنا هسه احنا كنا كأطباء، أنا راح أحكي بالعربي عمود ناخذ راحتنا بالكلام. احنا كنا كأطباء نعرف انه الactivities is indicated for about more than 10 years now, and it is available in every hospital and every emergency department and every CCU. It is available, and we have the knowledge, and we know how to diagnose the stroke. And many patients, they are reaching in window. It's almost every hospital with the surface of neurology, they have a CT scan most of the time. But the most important problem, the doctors afraid from using activities due to the possible complication, although it is very not common, at least it's maximally 3% maximally. But when it occurs, they are afraid from the response of the family, because in general situation in Iraq is not protecting doctors. If there is something happen to the patient, for example, if we have 1% mortality due to massive symptomatic hemorrhage, no one will protect the patient, the doctors. That's the major step. That's if you ask your colleagues throughout all Iraq, they are mostly using the activities with their relative and their friends. They are happy to do it because they feel secure when they are using the activities with their friends and colleagues and doctors especially. But with the foreigners, they are very restricted in using it. And that's why when I am asking my colleagues to participate in this work, to start to encourage to increase use of activities, most of our colleagues refusing starting using activities due to the general situation in Iraq. The Ministry of Health regulation, they are not supporting the doctor. Any patient would go to claim to the Ministry of Health about some doctor, they will say, this doctor is not listed in our drug list. Why you give activities? That's why we go to the Ministry of Health. We all go from top to base, not from base to top. We go to the Ministry of Health. We speak with the ministry and the board members. And the starting point is to protect our doctors by guidelines, by local Iraqi guidelines. After that, we start to organize the right way. We should organize the stroke unit for strict follow-up. And after that, I think there is, even if 10% only of neurologists start using it, and with the progress about 10% every year, so within 10 years, we will get 50% or more of doctors using activities for active stroke.
Okay, thank you, Dr. Tamim, for your participant. And now the question in the chat box goes to Dr. Ahmed. Please, Dr. Ahmed, talk about your opinion about using a lower dose, like 1.6 milligram per kg. It was using in several studies in China and Japan, which has lower risk of hemorrhage with the same benefit.
Yes, there is such research, but unfortunately, it not reach an evidence base. The evidence base thrombolytic therapy is only 4.9 milligram al kg. Other doses are used only for investigational purposes. They show promising result with less side effect, but is not proved yet. Maybe if they take larger number with and perform randomized controlled clinical trial, and if they show benefit, maybe approved in the future.
Excuse me, can I answer? I have a comment on this question.
Yes.
There is Enchantis trial, which is a trial in Chinese about the low dose 0.6 milligram per kg of RTPA, but it showed lower
efficacy.
lower efficacy than 0.9 milligram, although there was a lower number of hemorrhages, but it shows lower efficacy than 0.9 milligrams. So the guidelines and the FDA approved the 0.9 milligram per kg dose for the treatment of acute ischemic stroke.
Okay, for the questions, there were no questions left in the chat box. Thank you for all.
Thank you very much.
Dr. Mustafa, if you could unmute yourself, please.
Sorry. Thank you for all attendees. Thank you, everyone. We thank especially Professor Sarmad Al-Fahad, Dr. Mutaz Fayruz, Dr. Tamim Al-Tamimi, Dr. Srood Nizar, Dr. Ahmed Al-Salim, and finally Dr. Hassan Abdul Rasul for their participation in this webinar. And we also invite you to follow us on social media. On YouTube, we will download or we will upload the lectures on YouTube channel. We have a specific email and Instagram and Facebook page, in addition to our Telegram channel. And finally, we again invite you to join us by filling this Google form and waiting your valuable contributions to develop the work of this network. And last but not least, we would like to invite you to our next event. It will be on land, it will not be virtual, it will be in Baghdad, hopefully. And we will tell you the date as soon as we prepare the logistic issues. Thank you, everyone, and have a good day.
Mr. Dr. Mustafa, sorry to come in late. I don't know if I have 2 minutes from your participant. Okay. Just for contribution. This is Dr. Al-Rikabi Akhtam. Maybe some of you recognize me. I am a graduate Baghdad 1993. I'm a consultant stroke in UK. I just want to contribute for 2 minutes. Thank you for the invite.
You're welcome, sir.
And, yeah, and when we are using Al-Tablis, myself, I use it in the last 13 years. There is no harm. It's a very safe medication to overcome the Iraqi environment and circumstances. I think consent family agreement should be in place so you reduce. Safe practice, we have to set a protocol for needle, door to needle, and call for needle as well, which make it strictly 1 hour for